Welcome to the Healing Pause, a space where we slow down, listen inward, and have conversations that women were never taught to have. In today's episode, it's an important one. And it's so important, I have my computer in front of me because I don't want to miss a single thing. So for decades, women have been told that menopause is something that we just endure quietly, maybe fearfully, especially when it comes to hormone therapy. The Women's Health Initiative left many women scared and confused and unsupported. And yet so many are suffering through these symptoms very deeply, and they're affecting their quality of life. So I'm super excited about today's episode. I am joined by my friend, Dr. Brianne Brandt Griffith, OB-GYN, member of the Menopause Society, and she's going to help us unpack what we know now, what has changed, and how can women make informed, empowered decisions about hormone therapy without fear. Welcome to the Healing Pause, a soulful space for women moving through the powerful transition of perimenopause and menopause. I am your host, Dr. Christina Kintock, chiropractor, nutritional counselor, and holistic health advocate. Here we explore what it means to align your mind, body, and spirit through this season of change, from natural hormone support to nutrition, gut health, movement, and mindset. If you're ready to embrace midlife not as an ending, but as an awakening, you're in the right place. Each episode offers practical tools, compassionate insight, and empowering conversations to help you reconnect with your body's wisdom, find balance through the shifts, and step into your next vibrant chapter. This is your moment to pause, breathe, and come home to yourself. Welcome to the Healing Pause. So just a quick disclaimer. This is not about telling you what to do with your body. It's about restoring knowledge, choice, and trust. Before we begin, a gentle reminder, this podcast is for educational and informational purposes only. The content shared here is not intended to replace personalized medical advice, diagnosis, or treatment. Every woman's body, history, and health picture is unique. Please use this conversation as a starting point. And as always, consult with your qualified healthcare provider when making decisions about your care. So without further ado, Dr. Brandt Griffith is a dedicated OB-GYN who focuses on women's health across the lifespan, with a special interest in evidence-based care for women navigating midlife and hormonal transitions. As a breast cancer survivor herself, she brings both professional expertise and personal insight to her work, which allows her to connect deeply with her patients and audiences alike. Through clinical practice and speaking engagement, her passion is to empower women with accurate information, compassionate care, and practical strategies to advocate for their health. So welcome, BBG. I love that, Dr. Brandt Griffith. I'm so happy that you have said yes to joining me today because this is such an important topic. I think for far too long, women have sat in silence and have suffered. I know I shared my story before on a podcast, how I came to find bioidentical hormones or hormone replacement therapy and how I was really kind of hesitant. Mm-hmm. So for you as a practitioner, one thing just kind of off the top of my head here that we've talked about in the past is a hormone replacement therapy. Why is it so hard for women to find providers that know anything about hormone replacement therapy?
Well, I can tell you in my own experience through medical school and residency, my training, I think maybe 10 minutes was devoted to menopausal care. Unfortunately, I went through training when the Women's Health Initiative came out, and that totally kiboshed any sort of hormone replacement therapy for women. And so I didn't get a lot of training in that. And even when I was young in my practice, as a young woman, I attract other young women. And so a lot of my practice was, caring for obstetrical patients, young women who wanted birth control. And as I've aged, so has my practice, so have my patients. And I truly didn't get the knowledge about menopause until I went through my own breast cancer journey. And when I was done with going through all of my treatment, I was put into a chemically induced menopause. And once I was in that chemically induced menopause, I looked for providers that could help me with these symptoms that I was having. And there was no one. There was no one to help me. And so I basically was like, I need to help myself. And oh my gosh, look at all these women out here who are not getting any sort of knowledge or care.
Yeah.
And so I made it my personal mission to get trained as a menopause provider, to continue to read the research every day, to continue to advocate for women, and to continue to encourage my other colleagues to learn more about it and become certified, because we live in this world now where it is a huge topic.
Yeah. Don't you think it's our generation that's bringing that to the surface, that subject? I think for far too long, our mothers suffered through menopause because we didn't speak about it. And our generation is getting to the point where it's like, you know what? Bullshit. We're going to talk about this. Why do I feel like I'm going nuts? Why do I not feel like myself? And I've touched on that in the past. I too have spent 33 years in practice where my whole practice was focused on women and children from the time I left chiropractic school. And yet when menopause hit me, I had no idea what was happening to me. I thought I was going crazy. I thought I had all these health issues. Never correlated it with menopause because, God forbid, our mothers talk about menopause. And when you do ask them, oh, I was fine, I sailed right through. And then you think back, because, I was probably a teenager in the house when my mom went through menopause. And I think, did you just sail through menopause?
No, actually you didn't.
Yeah. And society expects us to just suck it up.
Yep. And I love my mother to death, and there was nothing available for her, but she, doesn't sleep. She tells me all the time I'm up for hours in the middle of the night, and I'm like, Mom, go, get treated. And she, tells me, well, women have been doing this for centuries, and Native American women did it all the time, and this is what we do.
And that brings up a really good point, because when people say this is what women are supposed to do, we're just supposed to accept to feel badly for a large portion of our life. The argument falls short, because when you look back historically, menopause average age is about 50, 51. It's getting a little bit lower now from my understanding. But, turn of the century, the average age of a woman was 53. So we lived our lives, we went through menopause, and we died. We're living a longer, fuller, more vibrant life, and we're demanding that we feel better in, quite frankly, at least a third of our lifespan. So why shouldn't we feel better? We deserve that to feel better. And, there's the old adage that the boomers are pissed, right? And that maybe will bring me back into my next question for you, is the boomers, many of them were put on some estrogen and they felt great.
Yep.
And then it was ripped out of their hands due to the Women's Health Initiative. And that's what, that caveat is the boomers are pissed. So maybe you could touch on the Women's Health Initiative. I know it's a very nuanced study, but it was probably one of the most harmful studies ever performed on women's health and set us back years and years, decades.
So prior to the Women's Health Initiative, estrogen was widely prescribed. And about 30%, at least in the Medicare population, was on some sort of prescribed estrogen. And then when the Women's Health Initiative hit, they put the kibosh on prescribing any sort of hormone therapy. And it only has started kind of gaining traction again, but we're only at about 3 to 5% of Medicare age group. And that's the group we can study because there is socialized records for that population of women.
Sure.
Yes, the Women's Health Initiative, really sidetracked or gave false information. I wouldn't say false information, but just the study wasn't properly conducted. What they were looking at in the Women's Health Initiative specifically was, does hormone replacement therapy decrease the risk of cardiovascular disease? And it does, but it depends on when you start it. And so in the Women's Health Initiative, they were starting women on hormone therapy who were just going through the transition, had just been through the transition, and then women who hadn't seen estrogen in their body for 10 plus years. And when you extrapolate the data, like we will never have a study this large, this funded for women, which is unfortunate. And I think we'll go into that a little bit more because you and I have talked about our feelings on the unfunded research out there that needs to be done on women. But anyway, so if you extrapolate the data and you put those women in age brackets that are, the safe estrogen replacement, and then greater than 10 years out of menopause if you haven't seen estrogen, and then placing a woman on estrogen, then when you look at that, the women who haven't seen estrogen for 10 years and then all of a sudden you give it to them, they have worse cardiovascular disease. But the women transitioning through, it's actually cardioprotective.
Yeah.
And then you add in the whole nuance of progesterone. And so the progesterone arm, and so if you have a uterus, you need progesterone because estrogen is the fertilizer for the uterus and progesterone is the lawnmower. And if you just add a bunch of fertilizer, that can develop into uterine cancer. So you need the lawnmower around to keep that nice and thin and not let that estrogen kind of go wild. But that branch of women that had estrogen and progesterone had a slightly increased risk of breast cancer. And this is why the study was stopped.
And is it true that even the authors of the study have now come out and said that it was some flawed research in how they went about it?
Well, and if you look at like absolute numbers versus risk, so when the media got a hold of the breast cancer risk from this trial, they reported it in the media as a 26% increased risk of breast cancer.
Yeah.
Well, that sounds huge. But if you look at the women that, like your overall risk of breast cancer, just in the general population is like 6 to 7% usually. Increasing by 26% is not a huge increase. Yeah. So maybe it's adding 1 or 2 women per 10,000 women, a year.
Yeah.
And so when you look in absolute numbers, it's much lower. But that doesn't sell news.
Right.
What sells news is 26% increase in breast cancer. And so that's why the study was stopped.
Yeah. Well, and you and I talked when you brought up women's studies. Last night we were talking and I said, how many gold standard studies have been completed on women's health in 2025?
Zero. I mean, it's just flabbergasting that the way we treat women is based off of studies that were done on middle-aged white men. So minorities and women don't have the research that white men do. And our bodies work differently. So even that blood pressure medication you're on, is that really the right one for you? Your body works so much different than a man's.
Yeah.
So it's research even at the lowest base that needs to be done on, do we metabolize things the same way? Is this standard for vitamin D and calcium? Is that really for women or is that just blanketly for everyone?
Right. And it's part of the reason they don't want to study women is because we are a little bit more complex. You look at a man and from about basically puberty on, their testosterone stays somewhat level, maybe more like a wave. When you look at what happens in a female body in just 1 month's time with hormones, it almost looks like my grandson had an Etch-a-Sketch. Mm-hmm. The hormone are all over the place. So where in that cycle do we study these women if we don't have an understanding of them? So I think that's a really important caveat to all of this is oftentimes women come in at some point in time to someone like yourself. And we've talked earlier that this isn't necessarily an OB-GYN issue. It's actually an endocrine issue. We now know hormones affect literally every system in the body, but they're not necessarily trained. So it is hard for women. I think the average time a woman goes in for help is 14 different times. So it's hard to find. So I think that's where it's really important for someone like yourself, where you have that Menopause Society, which, is taking a test so you have a better understanding it, so people know where to go, because that is also very difficult to navigate. It's kind of why I started some of the process I did, because when I went through it, I wasn't sure where to go. Mm-hmm. First time I went into my OB-GYN, I was new to, I've told my story that I'm fine, because we're taught to be fine. We're taught to just push through the chaos. And I'm telling her, and
what's the new word? Be resilient.
Hey, I got that tattooed even.
Yep.
During my whole process.
What does that even mean?
I'm not sure. It's still there, a reminder every day of you got this. And and I think I was going through is like I eat healthy, I eat my protein, I eat my fiber at sunshine in the morning, I do cold showers, I do this. And at one point in time, I just broke down and I'm crying because I said, I just don't think I can dry brush my way out of this. And I
seriously.
And my point was I was doing all the the lifestyle changes, right? Mm-hmm. Like I was doing quite a few supplements. I was doing all the right things, which are still really, really important.
Absolutely. It's not a one pill fix all.
And that's a really important part. So I went in and she said to me, can we talk hormone replacement therapy? And I said, no, I'm crunchy. I'm granola. I don't need that. And everybody gets through it without it. And she looked at me and she said, your body makes hormones. What's unnatural about that? And it was an aha moment for me.
Yep.
So I went home and I kind of stewed on it some more. I started doing some more research. So my point of this question is at what point in time, I think we've talked that, I wish I would have known 10 years ago what I know now. Mm-hmm. What is the age, with a little bit more research coming in, what age is a great time to start those conversations? One, when do we start these conversations? Two, is there an age group that it's best to start hormones? And maybe you can speak on that, because sometimes I wonder if I could have avoided half the stuff I went through. I mean, I don't have a crystal ball. We don't know that, but we do have a lot more information because I think women are demanding answers.
Yes. And so a couple of big caveats is one, you can still have a monthly cycle and be in perimenopause. Perimenopause can start anywhere in your late 30s all the way through your 40s. So because you are cycling regularly and having a period, just because that is happening does not mean you're not in perimenopause. There are no lab tests to tell us that you're in perimenopause, because when women are cycling or even irregularly cycling, if I test your lab on this specific day, it's going to be only that day that is shown to me. It's not going to show me, what overall your hormones are doing in your body, because every day is different. Just like you said, even in a normal menstruating, not in perimenopause, every day is different as our hormones go up and then they come down and then we have a cycle. But the difficulty with understanding perimenopause is, like, in our late 30s, we might be having pregnancies. Mm. We might have little children. Mm-hmm. We might have and we might have job promotions. We might not be sleeping well because we have a toddler we're getting up with. And then as we age, we might be taking care of older parents, as well as going up in our career. And then you become an Uber driver. And so there's so many life things thrown at women as we go through this process that it's very easy to just kind of blow it off as, oh, I'm stressed because of this, or I'm not sleeping because of this, or my hair's falling out because of this. So that's where it's good to bring up with your physician. And like you've mentioned, there's not a lot of teaching out there. It's getting better, as we're doing these podcasts and as the information is out there and as patients are demanding it from us.
Right.
I demand you talk to me about this.
Right.
Now, there are definitely providers out there that are more specialized in it, that have more knowledge base, but that doesn't mean that your primary care provider can't start the conversation.
Sure.
And by the time patients get to me, they've seen, like you said, 7 to 14 different providers. And that includes, like, Oh, you're anxious, so I'm going to put you on an antidepressant. Oh, you have heart palpitations. Then you go get this whole cardiology workup when heart palpitations can be part of perimenopause. There are over 62 different menopause, perimenopausal symptoms. Inner ear itching, changing of your voice. I mean, just very, very nuanced little things. And what I would recommend is keep a journal.
Yeah.
Write these things down. Talk about, like in that journal, what is going on in my life right now? And could that be part of it? Or these symptoms seem to be like, this is weird. Why is this happening?
Well, and often we think of the symptoms as hot flashes.
Correct.
Night sweats. I mean, those are the typical ones. And I find it interesting that it is now 62 known symptoms. The last, when I kind of started down this road, it was, 19 different symptoms, and then it was 27, and then it was 39, and now we're up to 62. Frozen shoulder.
Yes.
I had frozen shoulder. I had no idea that was from menopause, and it was a little embarrassing. I'm a chiropractor, married to a chiropractor, and I suddenly couldn't move my shoulder. I hadn't injured it. I never put two and two together. So that is very important to call out those symptoms, because what are some, you touched on some of them, but perimenopause versus menopause, the podcast is called The Healing Pause for a reason. We're not just talking about menopausal women. I want perimenopausal women to understand that we want to pave the way to have those conversations with our providers.
Right.
But so often we don't correlate these signs and symptoms with perimenopause or menopause, because in some ways we're just taught it's just part of aging. I mean, that was some of the mindset of menopause, is that's just aging. That's just aging. And again, we're now saying bullshit. If it is part of aging, how do I slow it down? How do I reverse it? How do I get on top of it? But when I think back to when I was probably most likely in perimenopause, and as you said, I was running around with kids, I just was flourishing in the chaos.
Yep.
And I loved flourishing in the chaos until the chaos just came up and bit me right smack in the ass.
Yes.
So you touched on them. Perimenopausal, what is some of the first signs that maybe those conversations should be had?
I think that it's like a change in your overall mood. So feeling more anxious.
Yeah.
Feeling more overwhelmed. Getting heart palpitations, which can be a sign of anxiety, but also can be those fluctuations of estrogen. Sometimes it is cycle changes, whether it's my cycles are shorter, or they used to be 21 days apart and now they're 36, or now I'm having these heavy, heavy periods and I used to be fine. Not sleeping well. Those are some of the things that we see kind of in that starting time. Hot flashes, vasomotor symptoms are when your estrogen is really low. That's when you get vasomotor symptoms.
Yeah.
And we can have a whole discussion about, physiologically why that happens and, how we can help that. But in that perimenopausal time, what's happening is that you're basically running out of eggs. And our eggs make estrogen.
Yeah.
And if you're running out of eggs, you make less estrogen, but your body is screaming that it wants estrogen. As we've said, it's everywhere. It's from the tip of our head, the top of our head to the tips of our toes. You notice your hair getting thinner. You notice some facial hair growth, maybe body odor changes. Arthritis, like your hips hurt or your shoulder hurts, or these are all those changes of low estrogen. And it doesn't need to all of a sudden, our bodies don't just like, there's not this downward gentle,
No.
into menopause. It's like one day I feel great. A couple days later, I feel terrible. Now I'm sleeping fine. Oh my gosh, I feel awful again. And that's because your body, it's like it's running out of gas. And all of a sudden it finds some gas and you go, and then it stutters.
Oh my God, yes.
And then it finds some gas and then it stutters. And eventually you run out of gas.
Every woman listening to this right now is like, oh, yes, queen. Yes, that is so me. And, you talked about labs and not necessarily being able to test for labs. It is one of those times that symptoms are our best marker. And is it true that most women, they don't necessarily always have the words for it, but all of a sudden they're saying, I don't feel like myself.
Absolutely.
I do not feel like myself any longer.
Absolutely. And after we work, and each treatment is different for each person.
Yeah.
Each woman. One, this prescription is not going to work for this person. And I usually tell my women, and it sounds funny, but I tell them it's like I'm making a witch's brew.
Yeah.
And I put the standard stuff in, but you actually might require the unicorn hair.
Right.
And you might require the dragon's foot. And so it's a constant conversation. And then as you transition from perimenopause into menopause, that brew changes. And I feel for those patients because, like I said, in my own journey with breast cancer, after I had chemotherapy, my ovaries were done. Just boom, cut off, no more estrogen. They just got nuked. And so I never had that perimenopause roller coaster. I just jumped right off the cliff.
Yeah. Yep.
And I honestly, if you look at
you were probably pushed.
I was pushed. Yes. I did not want to jump off the cliff, but I had to go. And so I really feel that treating menopause just on its own, boom, you're done and you're in menopause, is so much easier because everything is zero.
Right.
So whatever I give you is going to make you feel better, and
yes.
It's not going to fluctuate. And once we get a good regimen, I'm not going to have to adjust it as much. In perimenopause, it's an adjustment all the time.
Which is why it's important to work with a healthcare provider that understands. And you brought up a couple of really good points. You talked about and that hormone replacement therapy isn't necessarily going to be the catch-all, the whole picture. It is one part of a beautiful puzzle because women are a puzzle. And when put together in one piece, we're a mirage of just beauty of color and vibrancy.
That's
right. But if that one puzzle piece is off is where,
correct.
And sometimes people go, what is the connection with you and I? I talk about my journey, and as a holistic healthcare provider, I realized when I added hormone replacement therapy in for myself, yes, we're not going back to our 20s and 30s. We're not. We're bringing ourselves kind of
this is
out
not
of
the fountain of youth.
No. We're bringing I tell people it's like coming out of the basement to the first floor.
Yep.
Just level so that we can navigate many other aspects. And maybe for just a moment, we could talk about that there are some other things that can go along with that. Lifestyle changes, exercise, supplementation. We've talked why that is important. And I will be doing a whole podcast on supplementation and what I have studied, what menopausal women just overwhelmingly need to make those hormone replacement therapy work better. So let's talk on that. But I also want to touch on the fact that why that works as a whole system, because our body is complex. We're one
Correct.
whole system. But you touched on something that goes hand in hand with that, and that has to do with the fact that you said it affects our hair, our entire systems. Maybe talk for just a moment on why that is, because we now know there are estrogen receptors everywhere. So why talk about about the estrogen receptors and how some of those other things fit in to paint this beautiful picture so that we can become the best versions of ourselves.
Yeah. So, you hit the nail on the head with our joints, our frozen shoulders. We have estrogen receptors in our joints that make the fluid, that make the buffering material that goes between our joints. And this is why it can get frozen as that estrogen drops.
Hence the arthritis as well.
Hence the arthritis. But like you mentioned, lifestyle things are huge. So I can't be on hormones. So what else is there out there for me? Well, you know what? I do yoga. I do stretching. I take supplements to help my joints. I use massage. I have a personal trainer that helps work with me. So I have to do those lifestyle modifications, and then if you add estrogen on top of that, it just accentuates everything. There's no pill that is like, poof, it's going to make everything perfect again. And our bodies are aging. So you're never going to feel like, the frozen shoulder might go away, but arthritis is normal. And that's going to happen. With your hair, as you go through perimenopause and menopause, our dominant hormone after that estrogen fluctuates all over is testosterone. And androgens can attack the hair follicles. Hence why males have male pattern balding. We can have female androgenic alopecia, which is female balding, and then get, everyone's got the goat hairs.
What is up with that?
Yep. This is that testosterone that's floating around our body, is that now I call them the goat hairs, they kind of stick out. And my girlfriends and I have made this bond that if we're ever in a nursing home and we aren't with it, that they will pluck our goat hairs.
Yes, for sure. Yeah.
But, so that's another thing that happens with estrogen. Eyebrows get thinner, eyelashes get thinner. Our skin changes. Skin becomes drier. Skin, we need more moisturizer on our face, hyaluronic acid, so it's all these other little, like I said, the witch's brew. And in the witch's brew comes other things that can help navigate that whole time period.
Which brings me up to 2 points I want to cover. One quickly, and then I do really want to get into your story, because I do thank you for being so vulnerable and open with your story, and I would like to ask you some specific questions on that. But it is part of the reason why the Women's Symposium was created, which you will be a part of at the next one, because we do know it's not any one thing. It's about introducing tools to your toolbox. People might come to the Women's Symposium and learn about pelvic floor, or why it's important to eat protein. How do we digest protein now that estrogen receptors are actually in the stomach? So we can eat protein all day long, but if we're not digesting it. So that's, there's that. We have a psychotherapist that comes in, because we know there's estrogen receptors in the brain.
Yeah, they call it menobrain.
Yes. What did I just see the other day? That we're now called queenagers.
Ooh.
I like that.
I like that too.
Queen. We're turning into queenagers. And so the Women's Symposium is all about finding the right tools for your toolbox. And they may not be right at that moment in time, but knowledge is power.
Absolutely.
And knowing that in a community that you are not alone. And I think that's really important. So there may be people that listening to this podcast or that have come to the Women's Symposium that say, hormone replacement therapy isn't for me for X, Y, and Z. There could be numerous reasons why they don't feel comfortable on hormone replacement therapy.
Correct.
Others may go, oh, my thought process is old and outdated, which was me when I started really looking into the research, and because I learned too in college about the Women's Health Initiative and stay away from that. So with that said, because you are a breast cancer survivor and you're also a menopause provider and an OB-GYN, I'm going to ask you straight out. Do you have any issue with prescribing hormone replacement therapy for women?
Absolutely not. And every time I prescribe it, I said I would 100% be on this if I could.
That is super powerful. Powerful.
I mean, honestly, I haven't had a patient come back and say, oh, I feel awful on this.
Yeah.
They say, I almost feel myself.
Human.
Or I feel back to myself.
Yes.
And that is powerful.
So thank you for being so forthright with that. And we talked this morning that I think it would be really important to have you back to discuss the breast cancer journey specifically, because, you said you jumped off, and when I heard your story, I felt like you were pushed off. You really didn't have a choice, and it was like, fly, little bird, fly. And I think so often there are women like you out there that just hearing your story, I think would really impact them. So if possible, I'd love to have you back, and let's really delve into your breast cancer journey and how that can help, because you also have things in your toolbox
Correct.
That you can give patients who maybe have experienced breast cancer or have it in their family, or there could be caveat of reasons. Things that hormone replacement therapy isn't for them. I think it's really important for them to hear that there are options.
Absolutely. And, there are options, and like you said, it's tools in your toolbox. And a lot of women that I take care of that can't have hormone therapy for one reason or another, or don't want to be on hormone therapy. The funniest thing is that they say, I don't like taking pills. I've never been on pills. And I was like, yeah, I was never on pills either until I got cancer.
Right.
And now I take many a day.
Yeah.
And you know what? I'm okay with that because I feel good.
Right. Yes. Yes.
So it's this decision that it's not harmful to take supplements or pills, under the direction of a physician or a provider or, someone who's proficient in nutrition and a chiropractor. But it's not okay to feel crummy for the next 50 years of your life. That's not okay.
So circling back around to hormone replacement therapy, maybe for a second, if you would, what is the difference between hormone replacement therapy and bioidentical hormone replacement therapy? Is there a difference? Does it matter where you get your hormones from? And do you have an opinion? I think I'm asking like 3 questions in one here, so stick with me. Do you have an opinion on, how it's distributed? Tablets, patches, pellets? Maybe for a second, if you would speak on exactly what we know. Hormone replacement therapy generally is estrogen, progesterone, and now we're hearing more and more often testosterone, and why testosterone is important to women. So circling back around again, the difference between hormone replacement therapy and bioidentical hormone replacement therapy. I think that's a really important subject. And then the delivery system. Yeah. Thoughts on that?
I think the big question out there is that when a physician prescribes something, women think that this product is what we call synthetic, so man-made. And there's this thought process that bioidentical means that it came from nature. And I'm eating something or taking something that's, has nobody's messed with. And that thinking is actually completely false.
Yeah.
So estradiol, which is the dominant estrogen in our body, is what is supplemented for hormone therapy. There are other estrogens that we can supplement with, but if you are getting estradiol, you are getting a so similar to my body, identical, so that's the same makeup as what my body is making. That is what bioidentical means. And we have FDA approved bioidenticals. So it doesn't mean that because your hormone is tailored by a compounding pharmacy that is more pure than the one from the FDA. It's all the same base.
So basically all hormone replacement therapy now is considered bioidentical.
Correct.
Versus possibly when the Women's Health Initiative, that estrogen, if you would talk about
synthetic.
Synthetic.
And so synthetic is where you take the molecule, the estradiol, and you adjust it. So you esterify it or add something to it, and it changes the how that molecule works. And the big thing there is that some women, estradiol does not work for them. It causes symptoms. It causes, it may be detrimental. Maybe estradiol, their own, identical hormone, makes them more anxious. And so then this is where we can use these synthetic estrogens, which have different binding capability to different receptors. And so some women might do better on those. And so it's like you said, these are just tools.
Yeah.
This is not trying to say mine is better than yours. Now, the one thing, my own personal opinion is that when something is approved by the federal government or the FDA, it has really strict regulations. There has to be reportability of if there's any side effects, and the pharmaceutical companies that were approved need to be constantly reviewed. When something comes from a compounding pharmacy, they don't have those same regulations. they may opt to use a third party to come in and assess them. And that's what I suggest, is that if you are going to use a compounding pharmacy, you want to use one that's reputable, that believes in peer review or third party review so you know what you're getting. But every time you get something compounded, the makeup inside of that doesn't have to be precise. For an FDA-approved medication, it has to be precise. So if I give you this certain patch, it's got to have this in it.
So speaking of that, when you say compounded, so right now the FDA has not approved testosterone for women.
Correct.
I know there's been many providers that have gone in front of the FDA to testify of the importance of testosterone in women. So as far as distributing testosterone specifically, because this seems to be the subject du jour, and maybe this needs to be its own podcast as well.
I think testosterone is a huge topic.
It is a huge topic because we know that there are different ways to distribute the testosterone, and some of them are a little bit more controversial than others. Because it's not FDA approved, we often see those coming from compounded pharmacies.
Right.
And maybe I'm getting in over my head for this hour, but real quick, best way for women to get testosterone.
So my feeling is that the best way is transdermal.
Okay.
So that's absorbing through the skin. And testosterone itself has a 24-hour, bioavailability. So you can't just do the male version and do only one pump a week, because by the time you get midweek, you get a huge dose on Monday and it's gone. So you need this daily dose. Australia is way ahead of us.
Yeah.
They have a testosterone patch for women. They're working on a testosterone cream for women. So there's two ways to get testosterone for women. One is you prescribe the male version of testosterone, which is called androgel. And then you have to do this complicated dosing for it. And it's not covered by insurance, so it's all out of pocket. So you have to find a pharmacy that is comfortable distributing this, and out of pocket can be $300.
Right.
But a 1 month supply of testosterone for men will last a woman almost an entire year.
Right.
So you kind of think about that monetarily wise. The other option that I like to use which is a lot easier to use, is I do go through a compounding pharmacy, and I compound the medication so it's actually a female dose.
Right.
And so you do 1 click, 2 clicks, use that cream, and you rub it on your inner thigh or butt cheek or forearm, and that is absorbed every day. And so I like that because it's titratable. So some women, they say that the dose women should get, once again, is there research on this? Not quite sure.
Right.
We get it from Australia, so that's where we get a lot of our research because they've done a lot. But the dose is supposed to be 5 milligrams a day. In a male with hypogonadism or low testosterone, it would be 50 milligrams a day, so about 1/10 the dose. I've started on women on 5 milligrams, and all of a sudden they send me a message and is like, oh my gosh, I was driving to work the other day, and the road rage I had, I literally thought I almost ran somebody off the road.
Was this during construction season in Duluth though this past year? Because,
yes.
That might be a given.
But she said, I just felt so ragey, so angry. And that's because her testosterone was too high. So this is why I like the daily dosing, because we can kind of adjust. I'm not a big fan of pellets, and the reason I'm not a big fan of pellets is because you're not really sure what the dose the patient needs.
Yeah, so it's not that consistency.
No, and you just inject it, and you hope that it works.
Yeah. So that brings me up to another question. When oftentimes what we hear with bioidentical hormones is to be on the lowest dose for the shortest amount of time, and yet what I hear overwhelmingly from women, and you probably even more so, great, but you're going to have to pry this out of my cold, dead hands because I feel human again.
Yep.
I know for myself, I would rather, if we somehow find out that it shortens our lifespan, but I'm still riding bike and hiking and going till the wheels fall off, I would much rather live a quality life than quantity.
Absolutely.
So I know there's kind of the...
Yeah. And the sad thing is that I had to have a major life event to understand that concept of quality over quantity.
Yes.
Like, I don't want to live till I'm 100 if I can't move, if my brain's not there, if I'm super sick. I'm much happier passing at 70 if I die doing something I love.
Absolutely.
And so that's where I just recommend following up yearly. We reassess risk factors. We reassess how you're feeling. Should we try coming down a little bit?
Yeah.
Oh, nope, I don't feel good on that. You go back up. And this is just reassessing every year with your provider. It's not a one and done. And then sometimes there are risk factors that women develop that make hormone therapy way too risky for them. But as a patient, you get to choose that.
So we've talked about, and that is huge, by the way. I should have, let's emphasize that.
Yeah.
You are
patient
as in the driver's seat.
Is a huge thing.
Yes, absolutely.
And I can tell you your risk of X, Y, or Z is greater than 60%. And if you're like, I don't care, I feel terrible off of it, it is a conversation between you and your provider.
Yeah.
Even a person in my shoes with breast cancer, if you're like, I feel awful, there is still room for potential treatment if you accept those risks.
So we've talked about the quote unquote risks of hormone replacement therapy, which have been disarmed. Mm-hmm. For the most part, we are now realizing so I want to kind of flip to the benefits of HRT. So oftentimes the mentality still is there's risk, but I want to push back on that because I feel like there are risks involved by not going on HRT if it is appropriate for you. What are some of the biggest risks of not being on HRT?
The number one and number two biggest morbidity and mortality for women in their lives are cardiovascular disease and osteoporosis. Mm. And we tend not to think about that in our 30s and 40s. Like, why would I be thinking about my bones? I'm just trying to get through my workday. But osteoporosis is a huge risk factor for women. You normally trip or slip out of your car and you put your arm out and poof, it's broken, or your hip's broken. And 20% of women that undergo some sort of major fracture like that, hip fracture, will end up in the nursing home. Mm-hmm. And within the first year of being in the nursing home, 20% of those women will have died.
Yeah.
And so that is huge. Secondly, cardiovascular risk. When estrogen is cardioprotective. We know this.
Right.
It keeps your cholesterol lower. It helps your vessels. Once you're 10 years or more out from menopause, your body starts putting plaques places, stiffening your arteries, blood pressures go up, cholesterol goes up. And, our bodies function a little bit more like a man, like an older man.
Right.
And so because of that, heart disease is a huge risk. And there's other factors that can increase our heart disease risk. It's not like I'm going to give you estrogen and you're protected. It all goes into that lifestyle. Right. Like you said, this is a tool in your toolbox. So if, for instance, like myself, can't be on estrogen, which would be beneficial for bones, what do? Well, I maintain muscle mass because muscle protects bones. I, eat calcium or take calcium to help, strengthen my bones. I, take vitamin D. As you know, in the Northland, everyone is vitamin D deficient. Everyone. There's no way around it.
And oftentimes they don't even test vitamin D because it's not covered under insurance. It's
Correct.
a $20 test. I tell people, throw it in.
It's crazy because vitamin D, this is a whole nother subject.
I agree.
But low vitamin D has actually been linked to breast cancer. So
breast cancer, heart, dementia.
Yes. So
All
it's
of
like
those,
we can't test for it because it's not covered. Another thing is a DEXA scan.
Yeah.
You can't, insurance covers it at 65. Guess what? Osteoporosis is already there at 65.
Yes.
So then you have to take all these medications that may not make you feel good.
Right.
Or cause your jaw to osteonecrose or break down.
Right. The side effects are horrifying.
Yeah. So, I recently read a book talking about medicine, and it said that currently we're practicing medicine 2.0.
Yes.
Which means most of our treatments and assessments are after the fact. We're playing catch up. Oh, you have high cholesterol, let's give you a pill. We need to be practicing medicine 3.0.
Yes.
And what that is preventative medicine.
Yes.
But preventative medicine isn't paid for.
Right. Well, and that's the field I come from, right?
Right.
It is kind of the foundation of chiropractic is trying to figure out the root cause.
Yep.
And doing that preventative. And I think our worlds are starting to meld in the circles that are demanding for them to meld, right?
Correct.
So we know cardiovascular is the number one killer of women. And it's so interesting when oftentimes when I give talks, although women are really smart, they are really smart, and the word is getting out there, but so often when you would say, what's the number one killer of women, we often think breast cancer.
Absolutely.
It pales in comparison to cardiovascular disease, heart attacks in women. Also, they look so completely different in women than men. You talked about osteoporosis and the percentage of women that fall and break a hip that never recover and die from hip fractures. And the third one, correct me if I'm wrong, would probably be dementia. I think
Absolutely.
1 in 5 women are 5, I think it is, women are 5 times more at risk than men. So
Correct.
The question is why?
The other really interesting thing is that we see an uptick of autoimmune diseases as women go through menopause. So there definitely is some sort of connection
1
there.
in 5 women too. And once you get one autoimmune, you tend to get another one.
Like thyroid disease, multiple sclerosis, rheumatoid arthritis.
Yeah.
Taking care of pregnant women, you can really see what high levels of estrogen and progesterone do to autoimmune diseases because it really suppresses a lot of those during pregnancy.
Sure. I had the best hair ever when I was pregnant.
And then when the hormones fall off, that's when you see a flare of a lot of these like ulcerative colitis and Crohn's. And it's interesting. The biggest fear out there is breast cancer. Yes. By the time we're 70 to 80, 1 in 8 of us, and that has been increasing, maybe 1 in 6 of us will develop breast cancer. Yeah. But the amount that actually die from breast cancer is extremely low. We have great screening. We have great treatment. I don't think that should be so feared that you sacrifice most of your life for that.
Absolutely. So I want to make sure we get through all of our questions because I knew we would have this great conversation and I'm scanning through them because it's like, yep, I knew we would do that. And it's why I wanted my computer today. We've already done that. We've talked about I'm just on this one, HRT masking symptoms or is it supporting long-term health? And we have already established that, yes, there are definitely connections that this is for long-term health.
I think the thing that you need to ask yourself too, if a man was deficient in testosterone, 100% he would be taking injections or the pump.
Okay, I have to give
110%.
Absolutely. Let's talk about this for just one hot second because this also could be its
own
podcast.
For taking things when we're deficient in them.
Well, so often men will go into their urologists or what have you to get testosterone because they have low libido, but they're going home to their wife or partner or spouse or whatever it may be, who also is dry as a bone. So we're fixing him, but we don't care about her. Recently, I was doing some research on this, and I was sitting at my kitchen counter, and I didn't know this one until very recently. And I yell out to my husband. I said, "Hey, Tom, did you know that when a woman goes through menopause, we lose our labia? Our labia goes away." And he was like, from the other room, like, "Oh my God, what?" And I said, no. You need to listen and you need to hear this. This is important. We lose body parts. Actual body parts start to reabsorb into our body. And yet no one talks about that. And I said, here, and then he says, okay, tell me why that's important. I said, think about it. If a man's testicles just suddenly fell off one day, there would be a moratorium. There would be, the life would end as we know it. There would be drugs. There would be surgeries. There would be all kinds of things to correct that.
Well, you can just look at what is FDA approved for sexual health for men, and it's over 20 different medications. What is
all
FDA
approved within 6 months?
Correct. What's approved for women? 2 medications that insurance does not cover. And, you know, the research on it, one of them is just for premenopausal women.
Wow.
So it's there's nothing.
So you bring up a very good point there of advocacy. And I think I've said this like 4 or 5 times of all these podcast ideas. And as listeners, I want them to give us some feedback of what they'd like to see too. I think there could be a whole
I think that
podcast on advocacy.
There could be a podcast on every single portion of a woman's body.
Absolutely.
So we could do
Mind,
a whole
body, and
hour
soul.
on the vulva.
Yes.
I mean, really. Because how many women haven't even looked down there?
No.
To see their parts?
Do they even know what a vulva is?
No. And I had a neighbor the other day who didn't even realize that women peed from a separate hole than the vagina.
Yes.
And I was like, I am flabbergasted.
Yeah.
Like, how is this possible?
At one of my women's symposium, I had a person who I love to death that we had a pelvic floor therapist, and she showed a diagram.
Yeah.
Of the female genitalia. And this person came up to me and was a little bit aghast. Like, she showed a picture of the whole vagina. She said, I've never seen that before. I've never seen one of those before. And I love her. And I started giggling. I said, honey, you own one.
Yeah.
You own one. You've never looked down there? Oh, no. So I think unless and until everybody knows what a vulva is, why it's important to have labia, what it looks like down there, is menopause and perimenopause a trendy thing right now? Unless and until that is out there 100%, I say no.
Yeah.
I say no, it is not trendy, because I think you and I talked this morning and I was really happy with some of these stats, because when I first started some of my research, I believe it's 6.1 million of us will be in menopause in the next year, and only 3% were seeking help. We're not necessarily seeking help. And you said that number is starting to creep up to between 10 and 15%. I think that's beautiful. That's still way too low.
Way too low.
Until all of those 6 million women are actually having a conversation with a healthcare provider.
Correct.
Our jobs are not done.
Correct. And I just want to add a little caveat. It's like some women think, well, I'm through menopause. I can't be on any of this. But actually, data shows that within the first 10 years of menopause, it is still safe to go on hormone
I think that's
replacement
really
therapy.
important. Really important.
So just because your periods have stopped, and you know, if you're having hot flashes and somebody has said, yep, you're in menopause, you can still get treatment.
So with that and the advocacy, kind of circling around, tying up some loose ends, coming to the end here, I think this is a really important thing. This is a question that has come often to us. What if my doctor won't prescribe or even discuss hormones?
You find a new one.
There you go.
You find someone that will listen to you, advocate for you, care for you, and that may not be Western medicine. That may be a functional medicine provider. That may be a chiropractor. That may be
all the above.
All of the above.
Yeah.
And I think that getting information from everyone, like you said, knowledge is power.
So empowerment and advocacy. As a provider, what do you wish every woman knew before walking into your office to discuss perimenopause and menopause? And how can she better advocate for herself? Now, this might be a little bit of a rhetorical question and we could go on too long, but I do want you to answer that, because I think what we will do in the notes for this podcast is link almost like a questionnaire for people so that they are informed before walking in. Is there 2-3 things that you're like, this is what I wish women knew coming in?
Yeah, I guess I wish they knew that there is help out there. You know, I think a lot of them see one provider and are poo-pooed, or, you know, you have anxiety, or, oh, you're not sleeping. Here's a drug to help you sleep. I think that we're very poor at evaluating the whole body.
Yes.
But I also want women to know that this is not a quick fix. This is not something that you're going to take this medicine and then overnight, poof, you're going to feel like, you know, a 30-year-old again or a 20-year-old again. That is not real life. Real life is hard. This is work. If you are noticing weight gain in menopause, unfortunately, there are other things you need to do to help with that weight gain, because it's not menopause is a huge portion.
Right.
But it's also our Western diet. It's our stress level. It's our lack of sleep. I mean, there is nothing that's just you flip the light switch.
Right.
And so coming in to my office is a commitment.
Yeah.
I want you to be committed to bettering your health. This is the time and day and age to take care of you. We have been taking care of everyone our whole lives, always putting our kids first, our husband first, our colleagues first, our parents first. You know what? All studies show that if you put yourself first, you actually become a better partner, a better mother, a better friend.
Yes.
And so I think that the time is now.
That just gave me goosebumps. That gave me goosebumps. Well, and you and I have talked about this, that it's almost like estrogen for so many years was a protectant, right? Like,
yes.
It protected our brain. It protected our joints.
Nurture, caregiver.
It protected even our gut, our pancreas, all of that. And all of a sudden that blanket comes down and it's like the bullshit factor comes off.
Yeah. And you're like, wait a minute.
Yeah.
I'm not doing this.
And oftentimes we hear, what would you have done had you known then what you know now? To be honest, I think we're a little bit, personalities are the same. We're a little driven, type A. I would hope with the more these conversations happen, we realize that facade is not healthy. It's not a good facade to have, and that we're all kind of in the same boat. So
what do I wish? Okay, I do have the answer to that. What do I wish I would have known then from the person I am now? Start lifting.
Yes.
Start eating healthy.
Take care of your adrenals.
Take care of your adrenal glands. Take care of your gut. Stop, scrolling. Stop with the screens.
Say no once in a while.
Put up boundaries. Spend time with friends.
Yes.
They've shown that actually social interaction decreases the risk of dementia.
Yes. There's actually studies now that have shown by when women gather, on a chemical cellular level, we are changing the integrity of the mitochondria in our cells, the DNA in our cells. Yes.
That's what I would tell my younger self. I also was very type A, very driven, and I just kept going. Like I was a engine. Just, I think I can. And I'm just on this track, and I'm just working myself to death. And then I got shoved off the track.
Right.
And that's what it took for me to be like, oh, crap.
Well, and
I just missed that whole portion of my life. I mean, I was like so in it that I didn't stop to enjoy.
Right. Well, and it's why women, we see them leaving the workforce at a high rate in those perimenopause and menopausal years. So just calling out that awareness. Well, gosh, I feel like we could
go on for another hour.
We could go on forever. And I am so incredibly appreciative. Like I said, we will link that questionnaire for people who, when you go into your provider, so you can take a peek at that. There are so many books out there that are wonderful podcasts. PBS has the M Factor documentary is a great thing. So with that said, my friend, Dr. BBG, the big BBG, I am so honored and I appreciate you so much for being here. And I hope if there's just one thing that I hope you take from today's conversation is this, that menopause is not a failure. It's not a deficiency. It's not even an ending. It's a transition.
I feel like it's a beginning.
I agree.
I feel like it's a beginning because, like you said, the wool has been removed from my eyes, and it's about caring for myself now.
Well, and it's flipping the script a little bit, right?
It is.
Like it's changing that old conversation of that we're just going to shrivel up and die. And
I'm going to be complacent.
No,
or I'm going to
this
be
is our
demure,
time of power.
Or I'm going to, I should probably not say that. No. I say no.
I told
this
you
is
that
the age of no.
That filter is gone.
Yes.
So yes, I believe so too, like taking back our power.
Yep.
The Native American culture has a beautiful saying where they talk about, they honor the menopausal woman because of their wisdom and because they don't have those filters anymore. They can see things clearly. So I think you are absolutely right. It is not an ending. It is a beginning and it's a transition, and you deserve support and clarity and options as you go through it. I think community is huge. Women understand what we're going through. So often you probably hear this as well when you bring up stories and people go, I thought I was alone. I thought I was the only one. I thought this only happened to me. So I think that is super important. So you're allowed to ask questions. You're allowed to seek second opinions. You're allowed to feel well in your body. And I want to thank you again for coming today. I want to thank you for this pause with me today. It's a healing pause. If this episode resonated, please share with other women who need to hear this and that they are not alone. And until next time, keep listening, keep advocating, keep honoring, and working through your healing pause. So with that, Dr. Brandt Griffith, thank you. I honor you and I see you. Thank you, friend.
Thank you.
Thank you for joining me on this episode of The Healing Pause. If something resonated with you today, I'd love for you to share the show with a friend who might need this conversation too. It's one of the only ways that content like this can reach more people. And if you want to take your support a little farther, you can leave us a 5-star review. To dive deeper into holistic support for perimenopause and menopause, connect with me on Instagram and join our community of women moving through this season together. Remember, your body is wise. You are not alone, and this chapter is filled with possibility. Until next time, take a moment to pause and honor the woman you are becoming.